It gives me great pleasure to introduce our last speaker, good friend Peter Kovacs from Hungary. Peter graduated from the Albert St. Georgi School of Medicine in Hungary in 1994, and he did his subspecialty training in reproductive endocrinology in New York at the Albert Einstein College of Medicine. He's now moved back to Hungary, where he's the medical director of the Kali Institute IVF Center. And he's going to speak to us on a very trendy and important topic, which is the efficacy of recombinant LH supplementation for controlled ovarian stimulation in rFSH and GnRH agonist protocols.
I also would like to start my presentation by thanking the organizers for the invitation, especially to Gaurav Gandhi and Gautam Al-Akhbadia. The topic of my presentation is the efficacy of recombinant LH supplementation for controlled ovarian stimulation in recombinant FSH and GnRH agonist protocols. When we study a new medication or a combination of medications or a new stimulation protocol, we always go back to the basics and we try to see what happens in the natural cycle, what regulatory forces control follicle development. We do this despite the fact that a stimulation is not a natural process. It's not a physiologic process because it is not normal for the ovary to produce several follicles at the same time. Now, said this, we always try to apply the basic rules to the stimulation as well. So a primordial follicle, to reach the ovulatory stage, it's a long journey. It takes about 3 months. Most of this development is regulated by growth factors produced locally, and gonadotropins, FSH and LH, become more important during the last 2 weeks of the follicular genesis. When we use stimulation, we use in general two classes of medications. We try to induce multiple follicle development, so we need medications that will achieve this, but we also want to avoid premature LH surges and premature ovulation, so we need medications that prevent this. Now, both GnRH agonist and antagonist effectively block the pituitary LH and FSH release, and they result in very low serum LH levels during stimulation. The gonadotropins that we use are either pure FSH or LH preparations or contain various combinations of these two hormones. So if we want to study the efficacy of these hormones separately, then the patient with hypogonadal hypogonadism is a perfect clinical case for this because they produce minimal FSH and LH. And if we stimulate these patients with an FSH-only preparation, we can achieve follicle growth, but estradiol production will remain very low, and there will be no successful pregnancy. However, if we use an HMG, or if we combine recombinant FSH with at least 75 units of recombinant LH, normal follicle development can be achieved, and successful pregnancy will follow the stimulation. Now, most of the patients that we treat are not hypogonadal patients, but have normal gonadotropin levels. And when we treat them during in vitro fertilization, we suppress the endogenous gonadotropin production. Many studies looked at whether there's an adverse effect if we suppress the LH to too low levels. And the results are somewhat controversial. There are studies that showed no adverse impact on the stimulation and no adverse clinical effect at all. Others showed that the peak estradiol level was lower when the LH level was suppressed. There were fewer oocytes retrieved, and there were fewer embryos created. And the study by Westergaard et al. Showed that there was an increased early pregnancy loss with very low LH levels. The problem is that it is not well defined what this threshold is. Some studies use 0.5 units, other studies use 1.2 as the lower cutoff. Thank you. Now, they also looked at whether there's a problem when the LH level remains too high. And again, adverse effect of high LH level was reported as well. It was shown to have an adverse effect on fertilization rate, embryo cleavage rate, and pregnancy rates. We know that if LH is given in the second half of the follicular phase, it maintains the growth of the larger follicles, but it induces atresia of the smaller follicles. So if LH is overproduced, it may have this atretic effect on the follicles. Now, if we want to study whether there's a need for LH during stimulation, we can do one of two things. We can either combine an LH-containing product to a recombinant FSH product, or we can compare recombinant FSH to cycles where recombinant FSH is supplemented by recombinant LH. First, I'm going to discuss some studies where HMG was compared with recombinant FSH. A study by Bosch et al. Used the antagonist protocol, and what they found that the most important clinical outcome was not affected by the use of recombinant FSH versus HMG. Ongoing pregnancy rate, implantation rate, and early pregnancy loss rates were similar. With recombinant FSH, they were able to collect more eggs, and with HMG, they were able to achieve higher estradiol level. A similar study by Hampus et al. Using the GnRH agonist long protocol instead of the agonist found similar results. A multicenter study by Andersen and his colleagues using the GnRH agonist long protocol found similar ongoing pregnancy rate with the two products. They also found a higher egg yield with the recombinant FSH preparation. They also had two interesting findings. They found that the proportion of top quality embryos was higher in the HMG group, suggesting that it may affect embryo quality. The LH content may affect embryo quality. And they also found that there was less hyperechogenic endometrium in the HMG group, and they postulated that it may have a differential effect on endometrial receptivity. Another large study, the European and Israeli study group on HMG versus recombinant FSH, similarly to the previous studies, found no significant difference when it comes to the clinical outcomes. Now, obviously, when there are many studies, eventually meta-analysis will be done, and despite all its drawbacks, it's a useful guide for us. There are two meta-analyses that compared treatment outcome with recombinant FSH versus HMG. Both of them drew similar conclusions, and the odds ratios are fairly similar in both studies. The study by Al-Inani and al. Included 12 randomized control trials. The study by Kumarasamy et al. Included 17, and they both found a somewhat increased pregnancy rate with HMG, and both of these findings were significant, the odds ratio at 1.2. Now, if instead of using HMG, we now combine recombinant FSH with recombinant LH, this is another way to supplement LH for the stimulation. And in 2007, a meta-analysis of 7 randomized controlled trials was published by Kolibianakis, and there was absolutely no effect on any stimulation or clinical outcome. Everything was perfectly similar with recombinant FSH versus recombinant FSH plus recombinant LH. However, there are some studies that should be mentioned because they had certain subgroup analysis that may shed some light on who are those patients who actually could benefit from recombinant LH supplementation. The study by Mars et al. Used the GnRH agonist long protocol, and from day 6 of the stimulation, randomly assigned patients to no supplementation or to supplementation of 150 units of recombinant LH. Overall, when the whole study population was looked at, the pregnancy rates were similar. However, when subgroups were created based on age, those who were over 35 had higher implantation rate. Their implantation rate was about 6% higher and had a significantly higher clinical pregnancy rate. The study by Humaydan et al. Followed a very similar design, except for not on day 6 but on day 8 is when they started the supplementation, and they achieved a 2-to-1 ratio of recombinant FSH and recombinant LH in the supplemented group. Again, if we look at the whole study population, there was no difference in the clinical outcome. But rather than creating subgroups by age, they created subgroups based on the LH level. And there was a low LH level group when the LH was below 1.2. There was a mid group where the LH was between 1.2 and 1.99. And there was a high LH group when it was over 1.99. What they found is that the FSH need and stimulation duration had a negative correlation with the LH level. And the estradiol level showed a positive correlation with LH level. This is very similar to findings of previous studies. They also found that in the group where the LH level was high, over 1.99, the implantation rate was reduced. However, when they supplemented this group further with recombinant LH, they could correct this deficit, and the implantation rate got back to the implantation rate observed in the other two groups. In women over 35, the pregnancy rate was lower compared to younger women. And when women over 35 were supplemented by recombinant LH, again the pregnancy rate was corrected and it was increased back to the level of the younger women. Lisi et al. Studied patients in their second cycle. Those patients who had a poor outcome in their first cycle were supplemented with recombinant LH in their second cycle, and there was an improved fertilization rate and pregnancy rate in the supplemented group. And the randomized study by De Placido et al. Looked at what happens to those patients who have a slow initial start to the stimulation. The estradiol level fails to rise, the follicles fail to develop. Now, if these patients were supplemented with recombinant LH, there was an increase in the overall response to the stimulation and more eggs were collected. Now, LH can also be given at the beginning of the cycle, and the theca cells of small follicles do contain LH receptors, and LH will increase the androgen production, and the androgen is known to have paracrine effects on the granulosa cells. It increases sensitivity to FSH, and it increases aromatase activity. So the thinking behind using LH in the beginning of the cycle is that we may be able to sensitize more follicles, and we may be able to get a better response to the stimulation. The Louvaris pretreatment group used the depot GnRH for suppression, and they used 300 units of recombinant LH for 7 days before the start of the stimulation. And the only positive finding was that they had an increase in the 2PN embryos in the study. We also did a study of a similar design. It was a daily administered GnRH agonist, so a more standard luteal long stimulation. And we used 75 units of recombinant LH during the first 4 days of stimulation. We could not observe any benefit with this approach. So if we get to the conclusions, we can conclude that both FSH and LH are needed for successful stimulation. There is evidence for an adverse effect of both very low and very high serum LH levels during stimulation. It appears that the use of HMG gives us another 3 to 4% of pregnancies compared to recombinant FSH alone. We can also conclude that LH supplementation in general, so to give it to all approach, doesn't work. It does not increase pregnancy or live birth rates. However, it appears that there are certain subgroups of patients who may benefit from recombinant LH supplementation. And these are the women who are older, who are over the age of 35, and the theory behind the benefit is that they may have a lower receptor density, and therefore they may need more LH to get the LH effect. It also appears that those who had a slow initial response to the stimulation could benefit from LH supplementation, and this may be through the androgen paracrine effect. Those with extremely low, and it's probably below 0.5, and those with very high LH levels also seem to benefit from supplementation. Humaydan hypothesized that those with high LH level probably have low activity of LH, and this is why they may benefit from exogenous LH supplementation. But it's clear that further studies are needed to identify those patients who clearly would benefit from an LH-containing product or by the supplementation of recombinant LH.
Already their baseline FSH and LH will be high. So how adding LH will be beneficial in elderly women?
Because with aging, it's true for any receptors that the receptor content decreases. So certain medications lose their efficacy as women age. So those women who are older, they have higher endogenous LH level, which is due to the lack of negative feedback. But within the ovaries, the follicles that are left have lower receptor density. Therefore, they probably need more LH. In general, very low % of the LH receptors have to be occupied. It's about 1% of the LH receptors that have to be occupied to get an LH response. But older women with low receptor density probably need more LH to get this response.
Before starting LH supplementation, do you have any criteria that you do serum LH and then give according to the patient's LH level?
I do not do that because those LH levels do not necessarily correlate with response. So I myself do not measure LH during stimulation. And the threshold and the ceiling levels are not well defined. I mean, if you do, and if you get an LH that is below 0.5, you probably get a better response with an LH. I myself use LH or an LH containing product either alone or in combination with recombinant FSH for women over 35 to start out with. So I will assume that they will not have sufficient amount of LH.